Neurofisiología Clínica Aplicada. Para su conocimiento, es un placer, bueno, primero que todo tenerlos aquí. Sabemos de la importancia de lo que vamos a trabajar en el día de hoy y mañana. Para su conocimiento, este es un curso organizado por el Instituto Colombiano de Neuropedagogía y es desarrollado en el marco de las actividades formativas del doctorado en Neurociencia Cognitiva Aplicada. Este curso se propone con el objetivo de mostrar las nuevas tecnologías de punta no invasivas en el diagnóstico adecuado y el tratamiento de enfermedades que afectan el sistema nervioso central y periférico. Cabe resaltar que la investigación en Colombia y en la práctica clínica se ha visto limitada en gran parte por el pobre desarrollo tecnológico, sobre todo en temas relacionados con la medicina en general y especialmente el área de las neurociencias. Por esta razón, desde hace más de 10 años, el Grupo Internacional de Investigación Neuroconductual (GINCO) se ha preocupado por esta problemática, desarrollando investigaciones en el área de las neurociencias, hasta llegar a posicionarse como uno de los principales grupos en Colombia reconocidos por Colciencia. Gracias también al apoyo permanente del Instituto Colombiano de Neuropedagogía y de la Universidad de la Costa. Para dar inicio a este curso, démosle la bienvenida al doctor Ernesto Barceló, director científico del ICN y del líder del grupo GINCO, quien nos va a dar la bienvenida con unas palabras.
Buenos días. Con tanto enredo en el tráfico y calles cerradas, etcétera, se me quedaron las palabras que tenía preparadas, así que todo va a ser improvisado. Primero, en nombre del Instituto Colombiano de Neuropedagogía, de la Universidad, de la CUC, del Doctorado de Neurociencia Cognitiva Aplicada, les damos las gracias por la asistencia a este evento que para nosotros es muy, muy importante. First of all, I want to express my gratitude for our friends, Denis, Xenia, and Svetla. Primera vez que digo bien el nombre de Svetla. Thank you. Nosotros desde el doctorado, cuando se planteó hacer el doctorado en Neurociencia Cognitiva Aplicada, se quiso dar una orientación diferente a todos los doctorados que se habían o con los que contábamos en Colombia y en términos generales en Latinoamérica. Si nosotros miramos bien las características del doctorado, nos damos cuenta que es único, y nos damos el lujo de decirlo, que es único desde Canadá hasta la Patagonia. Contamos con otros doctorados en psicología, con énfasis en neurociencia cognitiva aplicada, pero realmente un doctorado en neurociencia cognitiva aplicada con las características de este es la primera vez que se hace en todo el continente. Parte de la formación que nosotros estamos venimos haciendo unos cursos como parte de la educación continuada que arrancan del doctorado soportado por la universidad y por el Instituto Colombiano de Neuropedagogía. Hemos hecho muchos eventos, la mayoría de los eventos en diferentes áreas del conocimiento de la neurociencia, y este en especial, que es en neurofisiología clínica aplicada. Ustedes dirán, ¿por qué neurofisiología clínica aplicada? Múltiples razones. La primera es que gracias a este tipo de doctorados nosotros pudimos acabar con esa famosa dicotomía que hubo hace muchos años de qué era orgánico y qué no era orgánico. Porque para mí, pues, la psiquis del individuo existe porque existe el cerebro, y eso es discutible o no, pero es la posición nuestra como neurocientíficos, porque es la única manera que tenemos de explicar por qué razonamos, cómo pensamos, cómo aprendemos. Y ustedes ven ahora, eso nos ha llevado al otro extremo, o sea, al extremo donde estamos en la era de la neurocosa, que es algo que nosotros venimos peleando y venimos discutiendo desde hace muchos años. Nosotros no podemos llegar al reduccionismo absoluto de empezar a hablar de neuroeducación, neuromarketing, neurofútbol, neuropolítica, neuroempresa, neurotodo. No, la neurociencia es otra cosa y la neurociencia aplicada a diferentes áreas del conocimiento es otra cosa. Este curso va a hacer énfasis en la neurofisiología, pero del cerebro. Nosotros vamos a hablar en este curso de cómo nosotros podemos hacer diagnósticos y cómo podemos hacer intervención no farmacológica con unos niveles de evidencia altísimos, aplicado a lo que nosotros querramos. Entonces, aquí no vamos a hablar de nada periférico, ni de músculo, ni de nervio. Aquí solamente vamos a hablar de cerebro. Y por eso tenemos el lujo, y creo que es la primera vez que vamos a contar con unos especialistas de la talla de nuestros amigos. Como son nuestros amigos, los tenemos, para nosotros son amigos, pero si vemos la hoja de vida de cada uno de ellos nos llevamos unas sorpresas increíbles, increíbles. La doctora Svetla Belikovska es de bélica, no bélica. La doctora Belikova nació en Bulgaria, tiene una trayectoria, ha trabajado en Italia durante muchos años, en Bruselas, en Novgorod. Actualmente trabaja con la Universidad de Novgorod y trabaja de base en Bruselas y tiene una producción científica impresionante que ustedes la van a ver aquí y que lo vamos a poder aprovechar. Denis tiene toda otra trayectoria de investigación en diferentes áreas del conocimiento y yo quiero y lo mismo Xenia. A Xenia tuvimos el placer de conocerla en Taganrog, Rusia, y fue una muy buena experiencia, aprendimos mucho de ellos y gracias a esto hoy podemos contar con personas de esta talla. Falta el doctor Andreas Keck, que es un médico cardiólogo, pero que se ha dedicado fundamentalmente a todo el área de la inteligencia artificial aplicada a toda el área de la neurociencia, con telemedicina, bueno, lo vamos a ver más tarde. Y viene también el doctor Bonavento, José María Bonavento, neuropediatra de Argentina, viene de la ciudad de Salta, va a hablarnos de su experiencia con redes neuronales y neurofeedback en manejo en diferentes patologías, principalmente en niños, sobre todo lo que tiene que ver con rehabilitación cognitiva en niños y cómo se ha aplicado esto a toda el área de la educación y la salud en general. Así que no quiero extenderme más, les doy muchas gracias nuevamente por haber venido, gracias a mis 3 amigos de las casas farmacéuticas que nos han apoyado siempre cada vez que nosotros solicitamos la ayuda de ellos, aquí están y gracias a ellos, gracias a la universidad, gracias al instituto podemos hoy contar con este evento que de verdad les digo que es único en Colombia y es la primera vez que se hace un evento de este tipo en Colombia. Muchas gracias, lo dejamos con la doctora, Melissa.
Bueno, ya como lo mencionó el doctor, contamos con estos reconocidos invitados y a quien damos nuevamente las gracias por todo su apoyo y por todo su compromiso al estar aquí con nosotros. Bueno, antes de iniciar la actividad quería compartirles un poco sobre la programación del curso. Vamos pues a iniciar con, el día de hoy vamos a trabajar todo lo que tiene que ver con diagnóstico, nuevas tecnologías para el diagnóstico. Empezamos con el doctor Denis, quien ya presentaré, seguido por un receso que vamos a tener a las 10:30, de 10:30 a 11, y continuamos con la doctora Svetla de 11 a 12. En la tarde, bueno, vamos a tener, luego el almuerzo, hora del almuerzo va a ser de 12 a 2 de la tarde, luego contaremos a las 2 con el doctor Andreas Keck, seguido también por un receso de 3:30, a las 3:30 a 4, y continuaríamos con la doctora Zenia. ¿Ya? Al finalizar vamos a hacer un panel de expertos con las cuales ustedes también podrán integrarse, y pues la idea es que sea un evento y un curso muy interactivo. ¿Okay? Bueno, sin más preámbulos, les presento a el doctor Denis, quien va a iniciar su presentación. El doctor Denis Samillin es experto en neuropsicología, jefe del laboratorio de videoelectroencefalograma del Centro Médico Privado de Neurología, Diagnóstico y Tratamiento de Epilepsia, Epicenter, Volgogrado, Federación Rusa. Miembro de la Sociedad Experta en Neurofisiología Rusa y de la rama de la Liga Rusa contra la Epilepsia de ILAE. Esperamos que este evento sea de su total agrado y que puedan aprovechar al máximo a nuestros invitados. Gracias.
Buenos días, señoras y señores. Thank you very much for your invitation. So many warm words that we've heard while we are here. It's really amazing. Actually, the topic which I would like to share with you today was founded or discovered for us after my 12 weeks of clinical observership in Cleveland Clinic Foundation. So I think this is one of the most famous and most serious neurophysiological schools all over the planet. It was founded by Professor Hans Luders, which name is well known to anyone who is busy with electrophysiology, with EEG, with epilepsy. So after returning from the United States, we decided that it is not good that in the whole big country, in Russia, there is no unified system of producing the EEGs, of writing the conclusions, and we decided to follow the American neurophysiology school and try to organize it. And now I would like to present you what we got for now. Okay, everybody knows that electroencephalography is a method of fixating of electrical activity of brain. It is well known for about last 80 years. The method was opened with Hans Berger, a very famous German psychiatrist. So until that moment, in the last 80 years, the electroencephalography was evolved, was erased, and now it is useful for in diagnosis of many diseases and disturbances of brain activity. So let me tell you a few words about the basic principles. So this is electrophysiology of brain. You have to understand that first of all, EEG was just made for epilepsy diagnostics. So the main idea, the main item of each neurophysiologist is the possibility to find the pathological, as we call, epileptiform activity in brain. So each one of us could understand that in gray matter there is always a kind of battery which is producing the electrical activity, and all of the rest is just our attempt to catch it on the surface. So we are trying to measure the voltage difference on a line between a pair of two scalp electrodes. So electrical activity in the cortex consists of two different kinds. First is action potentials, which is produced by axonal axons, and excitatory postsynaptic potentials, which is measurable by EEG, which is produced by the dendritic tree of a neuron. So there are two different kinds of potentials. The first is excitatory postsynaptic potential, which is well known, which when glutamate is released and we can see the specific wave on the surface. And the second one is the inhibitory postsynaptic potential, when after the release of GABA, we should see the wave of a different polarity. So this is the main difference in EEG in diagnostics of generating of physiological and pathological waves in the brain. You have to remember that only 6 square centimeters of synchronous cortex can produce electrical activity, which is measurable by EEG. So that's why you have to remember that if you forget to put 1 or 2 electrodes on the surface, you will not see, you will not receive a lot of information from the cortex, probably pathological cortex. As for the wave generating, when the synapses are working the same time simultaneously with a big speed on the surface, as a summation, we can see the spike. In other case, when the synapses are not working synchronously, on the surface you can see the waves appear with the time lag. So in the summation, we will receive the slow wave. So this is the main mechanism of forming the pathological epileptiform activity of brain. The most common is spike and slow wave. So this is an improvement how we can receive it. As for the placing the electrodes to the correct places, you can see the brain and the proximate localization of each electrode, because it is well known that the frontal cortex is very massive and sometimes it is impossible to catch the activity from the deep part of the prefrontal cortex. As for the temporal lobe, you know that it consists of 2 layers, an old matter and the new matter. So it depends on the localization of the focus. Sometimes it is not possible to catch the activity, interictal activity. So that means that the accuracy while putting the electrodes into their places is very, very important, because misplace of, for example, the electrode T3 to the other place will lead us to misunderstanding or missing of some pathological electrical activity of brain. So let me show you and just ask the question maybe mostly to myself. So this part of the waves is looking very, very scary. So we are not forgetting about why we thought to organize or to make kind of unification of the EEG producing and writing of the conclusions. So what is that? If anyone in the audience from the audience can answer that questions, that will be great. If not, then I will continue. Nobody knows. Okay, this is a physiological phenomena. Sorry. This is a physiological phenomena which is not well known as a hypnagogic hypersynchrony, which we can see when the patient is fluctuating between awake state and light sleep. But misunderstanding and low quality, low knowledge of the doctor often leads to describing those waves as a real epileptiform discharges, which you could imagine, which will lead to the diagnosis, to a many years treatment of epilepsy, which was not in the brain actually. Another situation, so the first point was that the doctor has to be well qualified, the doctor has to know all the classification of the EEG, pathological and physiological. The second thing, a lot of technical problems or mistakes which technicians can do while they are preparing and or making the EEG. So take a look at this discharge. It is look pretty bad. It is look like a generalized discharge without any focal beginning. But if we transfers into a different montage, it is seen, this flat channel shows to us that the nurse, the technician, put a lot of gel. So it makes kind of the road, gel road between the two electrodes, and that's why we couldn't receive the electrical activity on quite a big surface. It will be about 10 or 12 square centimeters following the physics. So after the cleaning of these two channels, at the same patient, few minutes later, we receive the focal wave in the right temporal lobe with the secondary generalization. So that means that in the first case, the diagnosis will be wrong and the treatment will not be good for that patient. Making the accuracy corrections turns us into focal epilepsy, different treatment, and we hope much better result. So we decided, okay, using the American recommendations of Neurophysiological Society and with some additions from our own practice, we suggested some montages set. First, longitudinal bipolar montages. You can take a look at this slide. There are different kinds of them, but mostly they are fronto-occipital or anterior-posterior. So each one of them you can use as the universal or maybe the basic montage for focal epilepsy identification. The next one, transverse bipolar montages. Again, you can choose between 3 different kinds of them, but all of them are very useful too, just for identification of the epileptiform activity. The next one, referential montages to the ear or sometimes to the mastoidal. It depends of the producer, it depends of the equipment you have. So referential montages are very useful, but I will tell a little bit later about their necessity. So again, you can choose, you can use them, or you can make the preferences on your equipment just to switch between them easily. And of course, additional referential montages with CZ reference. Again, there are a few different types of them from which you can use. Why I am describing this why I'm describing this? It is necessary to understand that having a kind of the classification will definitely ease the conversation between neurologists and neurophysiologists in different laboratories all over the country. Okay, and it is necessary to remember that referential montages will never show you the localization. So that's why the initial montages should be bipolar. In referential montages, it is only possible to measure the amplitude of any wave and its topography, negative or positive. Most of the pathological waves are negative, so they are going outside the brain. The positive means that it's the physiological wave. This is one of the hints to decide or to make the conclusion. So few hints for the producing of the EEG, because in the different countries, in the different facilities, sometimes not nurses, not technicians, but doctors are producing the EEGs by their own. So first of all, you need to check the biocalibration at the beginning of each exam. You need to check the impedance between the electrode and the brain surface and the scalp. And of course, you need to switch between a few different montages, as I showed you before, just to check is there a plane channel, which means that on the part of the brain there is too much gel that you have to get away. Okay, about the conditions and performance of performance, how to do the EEG, how long to do, what it should consist of. First of all, passive awake state with the closed eyes for about 20 minutes. It will be good, it will be nice if the patient could fall asleep for a while at that moment. The next is a photic stimulation. We use that protocol of blinking series, which we got from our Holland colleagues, Professor Trinity. She is well known in Europe as a specialist of the photosensitive forms of epilepsy. So how does it look like? So we begin to make the series of blinkings with the frequency of 1 Hertz for 10 seconds. Then we make a break for 5 up to 7 seconds. All that time the patient is lying with the closed eyes. Next, the same we repeat on the frequency 2, 4, 6, and then up to 60. Why it is so necessary to use such a big diapason of frequencies? In common, if we are trying to catch the response, physiological or pathological, usually it happens in the medial frequencies between 8 up to 20. But sometimes, for example, the old TV sets were working at these frequencies, 60 or 50 Hertz. So it also can evoke the pathological activity of brain, so that's why it is necessary. In some laboratories, some equipment, you can do the photic stimulation up to 70 or up to 100 Hertz. But sometimes, I think for the routine EEGs, it's not so necessary. At that time, when you are producing the photic stimulation, it is necessary, don't let the patient fall asleep, because if he or she will fall asleep, you will not receive any answer from the brain. So, as I told you, we are searching for photosensitivity, the photic response, and at the same time, we are checking the visual analyzer integrity. Next exam, which is very, very necessary to do, is the hyperventilation. You need to explain to your patient to breathe slow and deep for at least 3, sometimes up to 5 minutes. You can imagine a patient who is a professional swimmer or a professional saxophone player, for example. So 3 minutes will not be, you know, just warming up for that man. So that's why you can prolong this, the hyperventilation. So this is the most informative test for pathological activity appearance. It is really so. It was proven in the thousands of investigations. So don't forget about the hyperventilation hypersynchrony at any age. This is a physiological pattern. I showed you hypnagogic hypersynchrony when patient is fluctuating between awake and sleep. So this physiological pattern is common, first of all, in children, and but you can see it also in the adults and in elderly. So you have to remember about it all the time in order not to get the false positive pathological result. Next is eye-opening, activating. You have to do it for about 15 up to 20 seconds. Usually we produce it after the hyperventilation. So we are, with this test, we are checking the integrity of occipital dominant rhythm, which is common, which is physiological in all of the patients. The next thing is that structural lesions are producing pathological slow waves in any state of the patient. Saying with other words is that if we see the pathological waves even while the patient is with the eye opening, that means that we have to search and to check the MRI, for example, to see some structural lesions in the patient. As for the deprivation, you can choose it individually, but this is not a mandatory procedure as a phonostimulation as well. A few words about writing of a conclusion, because it's necessary too. Each neurologist is overloaded with the paperwork. So if we will send them a big letter which is consisting with a lot of digits, some of them will be not understandable for the neurologist. It will not be good. I think you agree with this point of view. So what we have to include in the conclusion? First of all, the information from the attending physician, consisting of case number, age of the patient, sex, diagnosis, neurological status, current anti-epileptic treatment, last seizure date, questions and desires and expectations. This part, I think, is the main. So this leads us to a dialogue between neurophysiologist and neurologist. So if we should follow the advices and expectations of the neurologist, it will definitely arise the percentages of findings, of pathological findings. Next point, the information from the technician. Again, exam number, date and time, level of consciousness, intellectual status, and all the activation procedures which you can do. It is not a secret to anyone that some of the patients can show the mental retardation, and that's why it will be simply impossible for them to breathe for at least 1 minute. Some of them, following their other diseases, they cannot do it just by their physical shape, physical state. So we have to remember about it, and we have to write it in the conclusion. Next is the EEG description. Conditions, background activities, slow waves, epileptiform discharges, some special patterns, activation procedures, effect. So, and that at that part you are simply describing what you have seen on EEG. The fourth EEG short interpretation with the usage of seizure classification following the questions of the attending physician. So now we are coming closer to the first point when I was telling you about the desires and expectations of the physician, of the neurologist. So if we can catch some specific pathological response from the brain or to find the seizure, we have to describe it. So talking about the seizure, in a case of any paroxysmal event, epileptic or non-epileptic, it is necessary to describe it sequentially and particularly with the precise localization of any movements and their simultaneous appearance with the EEG changings. It is called clinical EEG correlation, and it is written in all the books about EEG, about the epilepsy diagnostics. And at the end, in addition with our conclusions, we have to prove our findings. So we need to print at least 10 epochs in different montages, proving the described changings. So at the end, the neurologist will receive just a little result of a case which consists of one page of our conclusion and 10 pages with the brain activity in a different montages. But the main thing is the conclusion as well should include about 3-4 pathological signs. So that means that it must be short and certain. That is returned as to my words about a lot of paperwork which is killing each neurologist, I think, all over the planet. And of course, it will help to save neurologists' time and assign a correct treatment. This is declassification. Unfortunately, I didn't find it in English version, but I think it is recognizable and understandable in all the languages. So this part is the slow activity. This is Hans Luder's classification. The second part is the epileptiform discharges. Take a look, there is not so much of them. Third part is the special patterns, which you can see in different states, especially in the intensive care units with the patients. Next is coma. And the fifth, take a look, the biggest one, is the physiological variants of physiological waves which we can find on EEG. So this is very important because knowing this part will help us to identify a real pathological activity, not to miss or receive the false positive results. So this is how our recommendations in Russia looks like. They consist only about 12 pages, and it is written most of the information that I share with you for now. I think it's not a problem to translate it into English or into Spanish if it will be necessary for you or useful for you. So most of the information I gave with this lecture. So the main aim for the EEG in epilepsy diagnostics is, of course, finding the pathological waves. The second, their identification following the classification which I showed to you. Next one, diagnosis verification according to EEG findings, focal or generalized. Next, describing the pathological activity using the official terms, because in some countries, especially in my country, doctors with the low level of knowledge in epilepsy diagnostics sometimes trying to find very, very strange things on EEG. So that means that they does not understand what for this method is used when it was invented. So, in the conclusion, I would like to say that using the unified methodology will help us too, neurologists and neurophysiologists, to talk the same language, to ease the EEG description in different laboratories using the unified terminology and methodology, and especially for the scientific work too. It will definitely raise the detectability of pathological changes on EEG. Okay, exclude wrong ambiguous terms. For the EEG manufacturers to produce the equipment with the unified montage sets. So just not to to turn the life of the neurophysiologist into hell, especially after receiving the new equipment and then thinking, oh my God, what I have to do? I have to fix, I have to think of my own, which montages set, how to do the photic stimulation or hyperventilation. If there will be a unified paper, you can simply open it, take a look, just take it into the machine, into the computer, and then just follow your own presets. It will help to raise the quality of routine EEGs all over the country. Okay, that is my first part. Now let me go to the video EEG, which is you know, quite interesting too, I think, because talking about the video EEG, it is well known that video EEG is a prolonged routine EEG with some additions, with some different things. So let me start. So video EEG is the method of synchronous recording of electrical activity of a brain and at the same time movement video fixation. Each shoot consists awake and sleep state, the activation procedures such as photic stimulation, hyperventilation, eyes opening, then sleep. It is very, very important to catch the sleep. I will show you later why it is so important. The next thing, again, at the end of the examination, you have to repeat all the activation procedures which you did in the beginning. I mean the photic stimulation, the hyperventilation, eyes opening, and sometimes something else. If you would like to identify, is it an epileptic seizure, for example, or reflect one, for example, you can drop something on the floor to produce the loud sound. So scary. Some patients will show you the seizure, and finding the EEG changings, you will identify, is it a reflect seizure, which is non-epileptic, or this is an epileptic seizure provoked by the loud sounds, for example. Photic stimulation, you will do it according to patient compliance or attending physician requests. So, okay, it's not a problem. It is possible to modify it. How you can do it? You can prolongate the blinking time. You can ask the patient to open and close eyes during the blinking series. You can definitely add the odd frequencies of blinking. You can ask the patient to extend the upper extremities. All of this is attempt to evoke the photosensitivity, or in ideal situation, the photomyoclonic response, which we can call the epileptic myoclonic seizure. Let me show you a little video. I'm not sure that it's visible so good, but you see that the patient puts the hands up and take a look. We see the discharge on the EEG, and see the typical movement, which is well known as a myoclonic seizure. So if you are not making the photic stimulation, in most of the situation you will not catch the seizure in those patients, because this is the only kind of seizure which they can show you, and especially at night. So during the photic stimulation, we can see the physiological answer of the background activity, which is called the photic driving. You can see that after the beginning of this stimulation series, at the occipital region, we see the background activity which is strictly the same frequency which we are giving to the patient. Take a look, this is the patient, this is an adult. Sometimes photic stimulation will lead you to the photic driving, which is actually not so visible here, but you can see, or trust me, that in the right occipital region we see higher amplitude. Sometimes it is happened from different reasons. First, if there is a problem in the analyzer. The second problem should be because of the technical problems. If a technician puts the photic stimulator not in front of the patient, but a little bit to the side, so that means that the flashes will go only to one eye, and that will lead us to such situation. So the higher accuracy in every step during the making of EEG, and of course writing the conclusions, is very, very necessary. Again, hyperventilation. It should last at least 3 minutes. I wouldn't stop at this test for a long time. I explained it to you just in a previous lecture. So sometimes it is an attempt to evoke absence seizure, especially in the children or in the teenagers. So this is the, as I said, this is the most informative activation procedure for provocation of focal and generalized epileptiform discharges, or in ideal situation, the seizure. So let me show you how it looks like. This is our own experience. Take a look at that girl. She's blowing, she's breathing deep like a game, and then she suddenly stopped. No any movements. We can see the typical epileptic activity, which is well known as 3 Hz spike complexes. And then suddenly after the seizure, she returns back to a conscious. So we fixed the seizure. That was our aim. That was the thing which we were searching for. Another situation, another patient, but the same. Take a look at this poor boy. He was tired, just holding the hands. Take a look at EEG. Take a look at him. You see? His eyes are blinking. He's out of conscious. And we see the typical epileptic activity on EEG. So that means that having a video camera, the same time producing the EEG, even the routine short EEG, will help us to identify the nature of a seizure. I told you about hyperventilation, hypersynchrony when I was talking about the routine EEG, so now this is the moment to show you how it looks like. So this is the boy EEG, 5 years old, and you can see the diffuse slow waves, but without any spikes inside of them. This is maybe the main thing, the main difference between physiological and pathological waves on EEG. As I promised to you, now I can show you how it looks like, as it looks like in adults. You see, it is really looking very, very scary. But actually, this is a physiological activity. We can't see any spike inside those very high amplitude slow waves. And of course, we can see it in elderly. It is looking like this, but we have to remember about it. Take a look, this is a man 67 years old. Now let's talk a bit about, about sleep deprivation. So Gibbs and Gibbs, many years ago in the 60s, recognized that epileptiform activity significantly increased during sleep. Dieter Jans noticed that 45% of patients with generalized tonic-clonic seizures had nocturnal predominance. So that means that the main idea is to let the patient fall to sleep. How we can do it? Okay, we can use the sleep deprivation. It always depends on the various factors, such as age, mental, neurological status, and so on, so on. So we are trying to treat or to discover not the disease, but each patient individually. When to start the record on how long the deprivation should last. So in adults, deprivation for 24 up to 48 hours is a really common practice, because sometimes the patient came to the neurologist and said, okay, it's not a problem for me not to sleep for the whole day. Okay, let's change it. You have not to sleep for 2 days and 2 nights. And then, of course, finally, I think each one will fall in asleep. For the infants, it is better to start the record close the physiological daytime sleep, because the children, we know that little children, they are able to sleep sometimes once, sometimes 2 times per day. So it will be great if the patient will go with mom. Usually we recommend for the parents the children to be hungry, so that will help them to feed, and then after each meal each one of us knows that it's so good to fall asleep. For the teens, we start at the first half of the day. So this is an approximate time at when we which we follow just when we're talking to the parents. So the age less than 5, they have to awake a child at 4 a.m. The brain and the child is growing, so it can resist without sleep from 2 a.m. And all the group 1, 2 a.m., 12, 13 years after midnight, and a little bit older children, they can survive the whole night. But the practice shows that after the whole night deprivation, most of those young children, they are not able to survive the activation procedures at the beginning of the exam. So they falling asleep as you turn off the light. In one moment, sometimes it takes about 30 seconds up to 1 minute, and later you can see that the pattern is changed and the child falls asleep. In that case, that is not necessary to get him or her awake to make the activation procedures. We can do them later after partial awake during the exam. So a few words about sleep phases. There are 2 phases, REM, which is called rapid eye movement, and non-REM, non-REM sleep. The first is poor for epileptic discharges identification, and it needs to use special additional electrodes such as oculographic, which you can put here and here, just to fix the REM sleep, but it's mostly necessary for polysomnography, not for the epilepsy diagnostics. Non-REM sleep consists of 3 stages: drowsiness, sleep spindles, and delta sleep. First 2 are most informative for the localization of finding the focal or generalized pathological epileptiform activity. The next question we are asking to ourselves is how long we should do the exam. So let's do a little bit math. One sleep cycle runs for about 90 minutes. It will be great to make a record of at least 2 sleep cycles, so 90 minutes plus 90 minutes will be about 3 hours. Let's add some activating procedures, so the duration of the video EEG should be at least close to 4 hours. When we are talking about the patient who can show us the seizures during the sleep, it is preferable to make the examination for the whole night. Of course, it's not so easy for the technicians, because for them it is impossible to sleep, just to even to catch a nap for 15 or 20 minutes, because they have to sit in front of the monitor and waiting, you know, like a fisherman waiting. Will they be lucky or not in that moment? So about 8 hours of night sleep will be great to find. It will help us to find the pathological waves on EEG in the different stages. Okay, and finding a paroxysmal event could be a trigger to stop the evaluation. So it is logically understandable that the patients no one like when you are lost of consciousness, especially if some of the seizures are quite painful for the patients. They can fall to the ground. So that's why some of them misunderstand the necessity of the video EEG. Some of them are afraid of the consequences of this evaluation, but actually it is easy to explain that they are here, they come to us to prove the nature of their problems, the seizures. Are they epileptic or non-epileptic? So that's why I think it is not a problem to explain that it's a miracle, it's good when he or she could show us the seizure during the evaluation. If we are talking about the pre-surgical evaluation, some centers are making the scalp video EEGs as a part of the pre-surgical big program. So sometimes pharmacoresistant patients, they are telling us about different kinds of seizures, at least 3 or 4, sometimes more. So we need to find one dominant focus between few foci, even if we find them on the previous recordings. It doesn't matter on video EEGs or routine EEGs. So that means that we have to wait for 24 hours, sometimes up to the week. Okay, of course, you will need some special equipment. In that case, the electrodes are fixed on the head, not with the cap, but with a specific glue, which is called collodium, and the specific electrode paste, which is not going away so fast as gel or as water. Okay, if we find a seizure, what we have to do? It is necessary to make the patient visible for the camera, because the technician who is producing, who is making, has to know that following the last classification, which was in 2017 of ELIA, pays the most attention to the beginning of the seizure, to the first focal signs. During the seizure, the technician has to ask the correct questions. For example, remember the color for the patient, just to check, is he or she still conscious or consciousness? Then we are trying to examine the speech. So repeat after me. For example, today is a sunny day. Then we can show the pen and ask, what is it? For what you can use it? So there is a list of questions which well-equipped, well-educated technician must know in order not to miss any disturbances of conscious or different kinds of analyzer's fault. I mean, the patient couldn't see a thing or couldn't hear you or couldn't simply pronounce. For example, showing the pen, the patient can understand what you are showing, but blocking of the motor cortex making impossible to answer the question. So this is very accurate methodics of finding. We are always trying to find what's the matter with the patient. And of course, after the seizure, you have not to forget to ask about the color again, because most of the patients with the secondary generalized seizures, they produce the post-ictal amnesia. So they doesn't remember what was before the seizure. And it is very good for the identification. All that means that the technician must have high skills in seizure detection, must know the rules of behavior during the event, must have knowledge in epileptology, must work 24 hours a day for free. This is, an ideal situation, of course. People wouldn't sit in the front of the monitor all night long without any payments. Where to find such a person? I'm going to show you one example of the seizure and the behavior of our technician. I think she's the best all over the world. She has a pretty name, Marina, which means born in the sea. So you can see the patient. Take a look at his right hand. He knocked to the wall because he begins to feel something. He is explaining that there is something strange inside his stomach. Sometimes it's not easy to explain. And suddenly, take a look at his face. It's changed. The convulsions begins. He began to make the movements. She's showing the fingers. How many fingers you have? Remember the day. Repeat after me. So all of these questions which I described before. And take a look that she is always with the patient in order that he will not injure himself during the seizure. You see, he's making the automatic movements. The face is showing that he's all out of this world for a while. She's using the pain. She's trying to identify, is he unconscious or not? He is fluctuating between conscious and unconscious, or as it is called right now, awareness. What am I holding in my hand? She's asking. And he cannot answer. So the technician must repeat all of these tests few times during the seizure, because some of the seizures are short, about 30-40 seconds. The others can long up to 5-7 minutes. All that time we have to know at what moment the seizure starts and when it finished. So this is really a very important thing. Now a few words about non-epileptic waveforms. So some physiological waveforms, as I've mentioned before, are looking tricky and could lead the physician to misinterpretation and then as a result having the very, very serious diagnosis of epilepsy, unuseful treatment, and many, many other problems. I don't know how it is here in Colombia, but in Russia, if someone get the diagnosis of epilepsy, it will, following the rules, epilepsy is untreatable in Russia. So the patient could not ever have the driver's license, even if there is a age-dependent childhood epilepsy. There are a lot of problems. They could not go to the army, they cannot receive the permission for carrying of the weapons, for example, many, many problems. So if we are talking about epilepsy diagnostics, it is better to skip the only one founded wave, nor to describe it. Let me explain this point of view a little bit more. So if you meet the patient for the first time, you make the EEG. The patient said that it was some kind of a paroxysmal event, but it doesn't look like a common epileptic seizure. And during the exam, you have found the only one wave. Let's imagine if you try to describe this as epileptiform activity, what would be in the future? The diagnosis, the treatment, the problems, and the very, very poor life quality of the patient. Even if it was an epileptic seizure, it is better to make the routine EEG than if you will not receive any positive answer. You can prescribe the video EEG, on which we can definitely find, especially in sleep stage, we can find the specific waves, 2, 3, 5, maybe more. But that would be, you know, I'm telling like a collecting of a necklace, one wave up to another. If you collect enough, then you can describe it as a pathological activity. If no, it is better to stop yourself. Just hold on. This is maybe not an epilepsy. This can be some kind of another kind of seizure, non-epileptic seizure. So I show you before the hypnagogic hypersynchrony, which is really looking very, very scary. And that means that misinterpretation will lead to a wrong diagnosis. The second wave. So now I will show you a few situations, a few different waves from the fifth part of the Luther's classification. Not all of them, but most scary maybe. So this is a frontal arousal rhythm, or as it's called FAR, which we can meet in children. So those waves are looking really pretty scary. Next thing, which is called the mitten waves. They were discovered and described only about 15 years ago. So for the non-specialists, it's not so easy to see them, to recognize. But if the pointer is visible, so those waves in the frontal area are looking really scary. They are looking like the spike and slow wave complexes. But actually, it's a physiological pattern. Why it is called mitten? It's easy to explain. I hope that the interpreter translate to you what does it mean, mitten. So, because in southern countries, I think you cannot meet them. So, if you can take a look at these waves, first of all, they have the same direction, to the up. And after the spike, you can see the slow wave, which looks like the mitten with the fingers inside of it. So it is the main, I think, thing on which we can identify that this is a physiological wave, because the classical spike and wave complexes, they don't have such emittance inside the slow wave. And of course, switching between the different montages is helping us to understand that this is a physiological activity. But really, it is looking very, very scary. Next pattern, posterior slow waves of youth. From the definition, you can understand that mostly we can see it in children and in teenagers. So take a look at those waves. They're also looking pretty scary. They're looking like spike and slow wave again, but we can meet them only in the posterior, in the occipital regions, only in awake state, and we had not to forget that the pathological activity mostly evolved during the sleep, and this pattern only is visible in the awake state. The next example, the other patient. Okay, so summarizing all that I've told you about, the video EEG is really a useful tool for detecting epileptiform activity, first of all. It has a quite high sensitivity for catching different kinds of paroxysmal events. It needs to have a well-trained personnel. You saw during the presentation how our technician was working. So sometimes she is waiting for the seizure for 6, 8, sometimes 12 hours. But the technician has to be ready at any moment to run inside the room and begin testing the patient. So knowing the theoretical neurophysiological part helps to escape false findings or making the misinterpretation or making the bad diagnosis, which will lead the patient to the poor quality of life as well. So the duration and starting time of the exam could be comfortable for the patient. So we are not the enemies to the patients. Vice versa, we were learning and we are learning right now in order to get the new knowledge to help them. So if we can talk about the war, about the war against the disease, so we are at the same side with the patient, and it's necessary, it's very, very important to explain to them that we are fighting together, because at the end the result will be very, very good, because for now with the actual treatment, with the medicine, we can treat about 60 up to 70% of patients with epilepsy and let them live later with a full life. Thank you very much.
Bueno, debido a que tuvimos de pronto un atraso al momento de inicio, entonces no vamos a hacer receso, vamos a continuar directamente con la conferencia de la doctora Svetla Belikova. La doctora Svetla, también proveniente de Rusia, médico psiquiatra de la Universidad de Medicina de Sofía, Bulgaria, doctora de la Universidad de San Rafael, Milano, Italia, actualmente experto externo de la Comisión Europea de Bruselas para consultor de neurociencias en el Centro Nacional de Autismo, jefe de laboratorio para psicofisiología, médico de la Universidad de Nizhny Novgorod de Rusia, y tiene su práctica privada de Psiquiatría y Psicofisiología en Bruselas. Demos un fuerte aplauso a la doctora Esbelta. Bueno, si quieren hacer alguna pregunta a los doctores, también mientras la doctora Esbelta coloca su presentación, pueden hacer preguntas.
Yeah, my question is for Dennis. Maybe it's, I don't know, a little bit less linked with your topic, but I'm trying to find if we can modify, for example, the brain wave or the chemistry of the brain using hyperventilation, for example. Can we modify the chemistry of the brain?
Thank you for a good question. You know, actually, identifying the pathological waves on the EEG, we are not asking ourselves the questions about the chemistry changing in the brain. First of all, we are thinking about, is it a pathological or is it a physiological? Does it has meaning of the epilepsy or not? So probably, I think so, that during the hyperventilation, due to the rise of the concentration of the oxygen in the brain, the chemistry will definitely change. But I don't think that it will change, no, so tough, so quick.
I can give you answer. If we can change the biochemical. Okay. Okay. You know Nikola Tesla. Yeah, and he has one very nice expression. Give me electrical signal, and I can transform it in any kind of signal, including chemical. So it is actually it has been discovered a few years ago how changes in the electrical activity is changing the biochemistry, because it is starting a cascade of biochemical reactions, and actually it is, for example, alpha rhythm, it is very similar to what is happening in the brain when you are smoking cigarettes. And this can also give you an idea that we are, if, for example, with neurofeedback, we are improving alpha rhythm, we are changing also the biochemical status of the brain. Okay, now I need to switch my computer. First of all, thank you for your invitation. It is a big pleasure for me to be here. I'm very excited, and I hope that you will enjoy my lecture, and this will inspire you. How much of PhD students we have here? Nobody. Okay, good. How many people are involved in EEG? Okay. Very good. So, I will speak about quantitative EEG, and this is a method that allows digital representation of the electrical signal, and on the basis of this, it can be analyzed, it can be compared, and it can be used for statistical purposes. On these slides, I show here the usual electrical signal, like you know very well. And this is a mathematical transformation called Fourier transform, when the electrical signal became transformed from time to frequency dimension. And this allows to measure the amplitude at certain frequencies. So here is the the amplitude presented for certain period of time, 1 second, and here it is already transformed in hertz. So usually for the human brain we are using to study the from 1 to 40 hertz. So they are divided approximately in bands of 4 hertz. The first lower frequency band is delta, between 1 and 4 hertz, then theta between 4 and 8 hertz, alpha between 8 and 12 hertz, beta till 30 hertz, and gamma that started to appear recently in the publications. So there was some comment these days that only a few years ago nobody spoke about gamma, and then it was a big boom actually in the publications and giving too much attention to this band, and now it starts a little bit again to calm down. So if I simplify the role of these frequencies, we can divide their function approximately like this. Delta and changes in delta, they are giving information about changes in the metabolism of the brain. We pay attention on changes in theta activity when we are looking for problems and changes in attention and cognition. Alpha is first of all linked with the cognitive functions. Beta activity is also linked with the attention, and gamma is like an organizing activity that organizes all other bands. So here I would like to give you this simple example that it is known well that all the screens, all these electrical devices that we are looking, also the light that is fluorescent, it is going to destroy gamma activity. It is very, very easy destroyable by this artificial light. So therefore, people who are in the front of computer for a long time, they can have a lot of problems linked with the sleep, linked with headache and so on, for one simple reason, destroying of gamma activity because of the light. So some main parameters that we study in quantitative EEG. Amplitude, it is in the also in the ordinary EEG. Then power, it can be studied only in quantitative EEG, and this is the squared amplitude. So the power is important to study, especially in the cases when we have we can discuss possibility for dementia, because we can study the relative power. And relative power has this advantage in comparison with the absolute, that it is not dependent by the changes in the skin resistance, skull thickness, and these external factors. Here I present maps of the brain presenting the absolute power hertz by hertz. This is done with a special software, but actually it can be done very well with the software of Medicom, our partners that are presented here. And seeing the maps of the absolute power, when it is important, it is important in order to see the topographic distribution. Especially, this is a record with eyes closed, where the main activity is alpha activity, and here we can assess if the alpha activity is in the posterior part of the brain, and how high is the power in the occipital region. Quantitative EEG is very powerful when we have like very soft disturbances. So when you have stroke, significant traumatic brain injury, we don't need actually quantitative EEG. But the power is here when we have very soft signs. For example, person has chronic fatigue that is with unclear origin, or there is some problems with attention that are also unclear where they are coming from. And for example, this very, very simple presentation, can you give already a lot of information, for example, in cases with chronic fatigue. Usually, the absolute power, it is very similar in the parents and in the children. Okay, sometimes when I have a person with chronic fatigue, I used to measure also the parent or the child respectively, and to see what is the difference. And many times, okay, here we cannot see comparison with the normative database, but I already have my own knowledge in the head. So sometimes low alpha activity is already enough by itself to have chronic fatigue. And this already is giving you one direction for the therapy, that here you can do everything. You can give Chinese mushrooms, you can give what you want, but if you don't manage to increase alpha activity, what you can fast do with neurofeedback, the chronic fatigue will have a long story still. So, other information that you can get from this simple map is to see where is the alpha occipital maximum. This means in the interval between 8 and 12 hertz, where is the maximum of the power or amplitude. If you work with amplitude maps, it is the same. So this is so-called alpha peak frequency. And alpha peak frequency gives information about the speed of the brain. So it is very important and very useful in the practice that alpha peak frequency is very stable parameter for a certain person. So since 50 till 55, 60 years, we can expect very, very close to the initial value alpha peak frequency. So if we see in a certain person that alpha peak frequency is going to lower values, this can be a sign for further profound observation of the person, what is going on, and thinking, in destination cognitive problems, or thinking in destination of some abstinence from some stimulants. Alpha peak you can see also in a person to increase, and in these cases, first of all, you can suspect use of stimulants. So it is for assessing alpha peak frequency, it is good to have for a certain person more than one EEG. The same parameter is very useful also when we have children and we suspect if they have cognitive problems or the delay in the cognitive development can be linked with some other problems like or physiological problems like processing of the auditory or visually signal, or it can be linked with just educational problems. But I had already in my practice many cases where they are coming children with low performance on the cognitive test, and then I see, okay, normal alpha peak frequency, and then I know, okay, if I work with this child for a few months, it will go back in the normal class. So I think from practical point of view, this is one very important parameter. As I mentioned before, if we suspect a disease, it can be seen like a measure for the dynamic of disease. So, another accent I would like to put here, again linked with this simple parameter, is in regard to attention deficit hyperactivity disorder. I don't know how is the practice here, but in Europe they are giving very easy stimulants to the children. And it has been proven that if alpha peak frequency is normal or it is lower than the norm for the certain age, the stimulant will not work. So it appears that only 20, maximum 30% of the children actually have high alpha peak frequency, and only in these cases you can give with relaxation internal, you can give stimulants, but in other case it is only making worse. So sometimes for the analysis it is not enough just to see the absolute values, and we need to compare with a normative database. So how the electrical activity of this person is in comparison with the person of same age and same gender. Do know it doesn't work always wonderful. Sometimes, for example, I see alpha amplitude or power, it is looking normal, but I understand that, okay, having 5 microvolts, it is not normal. Okay, so sometimes the database, they have very large windows, but they are easy like a start for the analysis. And here I present results that are analyzed with one of the most popular databases. Actually, there is two big recognized databases, both they are from USA, and this is the database of Neuroguide. So, usually with this software, when I analyze a certain case, I'm producing around 150 pages of different analysis. This is one page of analysis. So then it is a little bit difficult, but it is giving a lot of information. Here you can see on the first line, here, comparison with the absolute power, comparison for the different bands in regard to the relative power, comparison for the amplitude asymmetry, coherence, phase lag. And here it is presented peak frequency, how it is the results in zeta score. Yes, if we have peak frequency that I explained it how important it is for the clinical practice, if we just have peak frequency and we don't have this comparison, we cannot understand where we are. And now, attention on another factor, another analysis that is very important for the practice, the amplitude asymmetry. Especially in the alpha band. Again, it has been proven many times in the literature that alpha amplitude asymmetry on the frontal electrodes are giving information, and with this parameter we can distinguish if we have endogen depression or it is secondary depression to other factors. So always the endogen depression, they have this alpha asymmetry in the frontal regions. And when it is with symptoms of mania, it is just changing. It became the opposite ratio. So this parameter is very comfortable when you need to understand if the therapy that you are giving is working well, because first you have changes in the EEG, and then you have changes on the behavioral level. So you can have a little bit faster information if your therapy is successful. Another interesting parameter is so-called coherence. Coherence is giving information how the different parts of the brain, how they speak functionally between them. And here I will present you two types of analysis of the coherence. It is very important and informative when we have traumatic brain injury. Second, when we have processes with demyelinization. And third, in the period of abstinence of stimulants. So here, on this picture is the typical picture of traumatic brain injury. So when I speak about traumatic brain injury and detection on the EEG, I have in mind traumatic brain injury that is mild. Okay, the other traumatic brain injury everybody can see, but sometimes person had some not very strong trauma some years ago. Person already forget about this and so on and didn't consider this like something important. But start headache, starts chronic tiredness. So then in these cases it is very important that we are able to distinguish the presence of mild traumatic brain injury, and okay, it is typical that the coherence, especially between left and right hemisphere, is decreased. You can see here with the blue lines, it means decreased coherence between the left and the right hemisphere, and this we can detect for all frequency bands. Here a little bit fun. Who knows what is this in the middle? Nobody has been to the Nordic countries? Okay, this is tobacco from the Nordic countries. It is used into the mouth, bocal. So they are small sachets with nicotine, but they are very strong, and then they consist nicotine about 4 times more than it is in a cigarette. So this is just simple exam, and it was it was linked to the fact that my patient, during the record of the EEG, I suddenly see, okay, a fast change in the brain activity, and this was the case to record and to analyze it. So the first picture here is the person who is dependent from the nicotine, but didn't use nicotine the last few hours, and the coherence in delta that is linked with the metabolism is decreased, it is low, and only 20 minutes after the brain is happy. So when I'm telling this example, when you don't have this tobacco here, because it appears that this is not typical only for the nicotine, but this is typical, it seems, for the all stimulants. Can you see it is not very this mark is going exactly where is the most important part. Sorry, I cannot change. So here is caffeine abstinence, and here is changes in the brain after use of the coffee. Here is the same with the nicotine, and here is the cocaine abstinence. So it appears that for the brain doesn't matter what kind of stimulant it is working on one and same way, in the sense the connectivity, the brain during the abstinence of the stimulants is like disconnected. And if there is people like me who are coffee lovers, they know that in the morning, before the coffee, you feel like your brain is disconnected, and you need a little bit, 1, 2, 3 cups of coffee, that it starts to work. And it is, okay, we explained this, that we are disconnected, but it is really like this. So, the practical application. I think that you already make your conclusions that this can have a big practical application. First, if you have patients that you suspect use of stimulants, You can in very elegant way, without announcing them, you can have already one idea, one hypothesis. Then, if you have these people who want to stop certain kind of of stimulant, you can use the EEG like additional motivation. I had a person who came for neurofeedback and who was very happy that I'm making every time electroencephalography, because this was additional motivation for him that if he is not clear, I will see. So this has also like improving the therapeutic influence and the contact with the patient. And finally, you can have objective measure how it is going your therapy. So, again, in this software, something interesting that I found for me is they have two important scales for assessment, objective assessment of learning disabilities and for traumatic brain injury. And it is presented with arrow in values that you can see how it is going your work. Here is presented the results pre and post treatment of a girl with learning disability, and actually the results from the EEG, they completely corresponded to what happened in real life. It was a question of not very long period, I think less than 1 year, and she moved from special class to normal class, and it wasn't a very complicated case. But I'm showing this in order to show that the EEG values and assessment, they when the database is professional done, they correspond very well to what is happening in the real life. Another type of analysis that, if somebody knows this analysis, Loretta? Okay, this gives possibility. This is EEG, represented in three-dimensional, This approach in general is mainly used in the research, but it is very comfortable to help you also in the diagnostic part in the everyday work. Loretta, you can find free online, but without possibility to compare with the normative database, or you can find in NeuroGuide software where is with possibility to compare with the norms. So here, for example, is presented a case person with depression who has changes. This is the insular cortex, which is typical part where we can find some abnormal changes if we have affective problems. I just go to show you what kind of possibility we have, what kind of information we can obtain with quantitative EEG. Okay, this is looking a little bit like a picture, and this is actually, again, Loretta, so 3-dimensional, it is taken from Loretta information, but this is coherence between different Brodmann areas in one hemisphere. So, with blue, it is decreased coherence. So here, it shows the coherence between the important Brodmann area 10, which is the frontal, and many other areas. So we see like a functional disconnection in the frontal activity here, and it is in the right, it is opposite, we have hyperactivity. So this is here presented like a picture, but it can be exported like a numbers. So this again can give you very real information how it is going your therapy. What is happening in the connectivity in the frontal part, but it is not only for the frontal. I'm using this approach very much also in autism. It is very applicable, and again here we can use with zeta score first to have one idea where we are, and then we can use absolute values exactly to measure how it is going with our therapy. So a little bit about even related potentials. Meanwhile, the resting EEG, where I started, and I understand now that I didn't tell you how long record we need. So the resting EEG is very comfortable for analysis and for information because actually it is very good repeatable, and we need just 1 minute very good record that we can pretend that our result is good. This is from statistical point of view. Then this means that we should have from practical point of view like a record of 5 minutes with eyes open, 5 minutes with eyes closed. But you just can understand that with 10 minutes record, you can already have very profound information. So the even related potentials okay. Okay, good, good.
Bueno, no es que le haya quitado la palabra a la doctora, sino que yo sé que este tema es un tema nuevo, es un tema no fácil, bastante pesado para la mayoría de los que estamos acá. Entonces, como acabamos de terminar todo lo que es eje cuantitativo, a mí me gustaría, sobre todo en términos de investigación y de la parte clínica, aquí tenemos residentes de neurología, psicólogos, docentes, etcétera, médicos de todas las especialidades. Me gustaría que hiciéramos todas las dudas que tengan con respecto a lo que es el electroencefalograma cuantitativo, el QEEG, a ver qué dudas tienen y aclaremos las dudas, porque la idea de este curso es que sea igual interactivo, ustedes participen y nos digan antes de pasar a esta parte de potenciales evocados, que es todavía más complicado que QEEG. ¿Preguntas? Si no hay preguntas y les quedó todo claro, seguimos. Ajá. Yo tengo varias. I have many questions.
Doctora Svetla, I have at least 4 questions about neurofeedback, but well, you say that low alpha is an immediately sign of chronic fatigue. So which protocol will help that patient? Okay. You say that low alpha is an immediately sign of chronic fatigue. Is that correct? Yeah, low alpha, it's a sign of chronic fatigue. Okay, my mistake. Then the other question. Which wave can we stimulate to help the brain keeping sharp, at least from attention, memory, process? I mean, ¿qué tipo de ondas deberíamos estimular a nivel general en el cerebro para mantener por lo menos los procesos cognitivos básicos afilados?
Everybody wants to know this. Okay. It is known in general that alpha training is always good in the sense it is improving the cognitive abilities. In addition to helping the people to relax. Okay, just here a little bit a story. When I was in Italy, we investigate the brain activity in the Olympic team of fencing. And I was very impressed that the Italian Olympic champion, he had so beautiful alpha that I will never forget. So for me, this is a simple example, but it is not my impression. It is written in all books, just personal experience. So 2 years ago, I had students from Oslo University, and we developed one protocol. We tested actually one protocol which was based on theta coherence, and it was directed for increasing visual attention. So it was done the training in 12 sessions, and the results were analyzed with eye tracking and special software for visual attention. So we found that after 7 sessions of half an hour, there was already stable effect in the visual attention. But since it was not very big group, I'm waiting to replicate this result in order to publish it. But actually, it is interesting how we arrived to this protocol, and the protocol was inspired. We analyzed what is happening in the brain during certain tasks. So here I'm going back to the EEG, that if you have certain certain aim, certain task, you want exactly this function, you can make the task, you can register the EEG, analyze what is involved there, and go already very precisely to improve these functions in the brain. This is fine? It was my protocol that I developed. Yeah.
Buenos días. En el estudio de coherencia se puede, entendí que se puede utilizar para estudiar que nos sirve para estudio de pacientes con adicciones. Sí nos puede permitir tratar de ver un tipo de adicción en especial, es decir, el paciente con una adicción a cocaína, si introducimos cafeína, hay una diferencia en el estudio con respecto a otro estimulante.
So, I will tell you my own experience since first. Okay, there are studies, but there is no comparison between caffeine and cocaine. In general, when we have patients with cocaine, they have very fast changes in the alpha peak frequency. So, it is going from higher than the normal zeta score till very low in the zeta score. Plus, you can see these changes in the coherence that I showed to you during the abstinence, the coherence. So, in the users of caffeine, there is not these changes in the alpha peak frequency. So there is coherence, but alpha peak is there. It is not going up and down. So I can recommend you this, like to distinguish. Of course, the patient can tell, I just drink a lot of coffee, but this is not the case. And increased alpha peak frequency, it is presented in many articles that this is typical for cocaine. Increased, yes. Yeah.
Buenos días. Tenía dos preguntas. La primera es en relación a si se han usado estos dispositivos como emotive device para efectos de medir las señales electroencefalográficas. Y la otra pregunta es si con la data que ustedes colectan utilizan algún tipo de algoritmos como redes neuronales artificiales para efecto de predecir el comportamiento de deficiencias cognitivas de los niños.
If I understand well, you're asking if I have experience with emotive. No, because it is with few electrodes. So I'm habituated more to work with 19 electrodes, and this is the number, minimum number, that already is giving you real information. Then when we speak about the quality of the signal, of course, it is very, very important. Okay, the device is very important. What my data that I show it here, I obtained it with Medicom, with device of Medicom that is really very good in the from point of view of quality of the signal. I have been used it before also other devices, but when you go and see in the how you project the data in the Z-score database, and you understand if the quality of the device and the electrical signal is good or not. Because, of course, first of all, you should have very good device that you can rely, that the value is what you want to have. So I will not recommend these cheap devices that it is not clear what quality of the signal that are giving. Excuse me, what was the next question?
Es relacionada con la data. Cuando ustedes colectan la data, luego de ello utilizan técnicas de machine learning para efectos de hacer predicciones, por ejemplo, redes neuronales artificiales.
No, unfortunately, no. It can be applied for some more simple. Okay, it can be applied for some pathologies, but it depends of the pathology. For example, if we speak for Alzheimer, this is very good idea. Okay, I have in the past. It wasn't with machine learning. It was with other softwares, analytic softwares, to predict, for example, if people with mild cognitive impairments will go to Alzheimer's disease or not. But this was longitudinal observation. We had already the output, and it was just to find the predictive factor. But I don't have experience with machine learning for this. Otherwise, for some pathologies, like it is, for example, autism, like it is dyslexia, if you like, depression, they are not homogeneous changes that can be a result of many, many different causes. So it is very difficult to put several parameters internally and to go with machine learning. If you have some idea, I'm open and with pleasure will hear your idea. But of course, this has big application in the EEG. But for certain pathologies, it is more applicable, and for other less. Yeah.
Buenos días. Bueno, para mí resulta interesante cómo esta tecnología puede contribuir no solamente a diagnósticos, sino también a los efectos que tienen los tratamientos en diferentes condiciones. Sobre todo, digamos, por la aplicabilidad que tiene para la investigación en neurociencias. Quisiera de pronto saber si en algún punto esta tecnología puede reemplazar o no, o sea, por ejemplo, los estudios con electroencefalograma que fueron mostrados. Lo digo, o sea, porque de pronto para personal o profesionales que no están en el campo de la medicina, solamente mirar las imágenes y comparar de pronto un estado de una condición anormal y posterior de pronto la imagen con tratamiento, resulta de mucho más fácil ver la lectura de la imagen, digamos, de la actividad eléctrica. Entonces, por eso la pregunta es si en algún punto esta tecnología puede llegar a reemplazar electroencefalograma clásico o la lectura que fue mostrada anteriormente por el doctor.
They're two different things. I think that there is no some conflict because the different methods are applicable to different things. Okay, for epilepsy also there is, for example, neuronal networks that can detect but they are just different approaches that we need in different pathologies to use different approaches. Can you formulate a little bit shorter your question in regard to the children, because you were a little bit faster, and just please try to simplify the question.
Preguntaba si podría esta tecnología reemplazar a electroencefalograma tradicional,
No.
sobre todo en el análisis
No,
de
no, no.
algunas condiciones.
Okay, it is based on the traditional EEG. We start from traditional EEG. We need to understand the traditional EEG in order to select what is good, what is not good, what is artifact, what is something that we don't need for our analysis. So this is just one step further, and it doesn't exclude the traditional EEG.
Ok, doctora, en algún momento usted mencionaba que la onda gamma podía ver afectada con una larga exposición a los computadores y que esto puede ocasionar un trastorno o trastorno del sueño. La pregunta es, ¿podría aclarar qué tipo de monitores serían los que causarían esto y si los celulares entrarían también en esa dificultad?
Okay, I'm not engineer, so this is not exactly the question to me, but there is already publications about this, and we also, for example, in Russia, in the Department of Autism, when we made our EEG records, some of the records we made, because the children were not very calm, we made with planchettes, and it was very easy to see how was in the beginning the electrical activity before we added the planchette to the child, and how it was in the end. But don't rely on my just personal experience. You can see there is already publications about this in PubMed. Yeah.
Hola doctora, buenos días. Dos preguntas. ¿Cuál es la importancia de la tecnología que usted presenta en la comprensión y el conocimiento del dolor crónico no oncológico? Dolor, pain chronic. Chronic pain.
Yes. So always when we have chronic pain, we have changes in two structures, in the anterior cingulate cortex and in the insular cortex. And the anterior cingulate cortex is obligatory. The insular the insular cortex sometimes is easy to detect, sometimes it's not easy to detect. But I had people with, in my personal experience, okay, I had people with chronic pain and changes in the anterior cingulate cortex were very parallel with the changes in the state of the chronic pain. And it was able to be detected with, I present you, Loretta, this three-dimensional. If you remember, if you not, I can go back with the slides. And it is very easy to measure the level of the activation of the cingulate cortex or the insular cortex, so both of them. Otherwise, there are also publications about chronic pain and cingulate cortex. So it is possible to be measured objectively using quantitative electroencephalography.
Gracias.
Oh, it is a big pleasure for me that we have so many questions. It is great. Thank you very much. Okay. Can I have a cup of coffee because my coherence already is down?
Do you want to continue to the about 20 minutes? Yeah, more, and then we.
No, I have 10 slides more. But let you say something else. Before to rely on QEEG, you should have in mind this example of the father of the EEG, Roy John, what was giving this example. He was showing two brain maps and asking, okay, this is one and the same person, what do you think that is happening here? Why this big difference? And then the simple answer is that on the second one that seems very, very different from the first, the person just wanted to go to the toilet. So when you start to observe your patients, be sure that they feel comfortable, that they eat, that they have no special physiological needs, and so on. So this is very important. Yes, exactly. So till now I spoke about resting EEG, evoked even related potentials. They are generated in the brain when there is some discrete external or internal event. So the most usually we apply in the clinical practice cognitive potentials that are auditory or visual. In general, more applicable in the clinical practice are auditory evoked potentials, since they are more easy to be repeated. And this is the very simple example of the most used so-called oddball paradigm, where the stimulus, they are presented in the 30% of the stimulus are rare, like you see this nota that is up, and the rest 70% that they are often appear at stimulus. So in this paradigm, it is what is creating in the brain is several waves. The first one is P50, N100, P200, and when the stimulus is rare, it is creating P300. So the difference that is creating in the brain electrical activity between the often appeared stimulus and rare appeared stimulus, this is the wave P300 that is with red. This is the most important, the most used actually paradigm for study cognitive functions. And it is important to measure the latency of P300 and the topography of P300. So in the slide that we previously see, the first way, N100, it reflects the active attention. So P300 has maximum on PZ and has a latency between 250 and 500 milliseconds. In Alzheimer's disease, the latency is increasing and the amplitude is decreasing. And again, you should take in mind that not always the amplitude, low amplitude, is giving a lot of information because it is very easy to be manipulated by the blood sugar. So P300 has meaning to be studied mainly in the longitudinal studies. We tell that it is very used in study cognitive functions and Alzheimer's disease, but if you have longer P300, this doesn't mean that it is obligatory Alzheimer. Another paradigm and another potential that is using to be analyzed is mismatch negativity. What is the difference between P300 and mismatch negativity? This paradigm can be used when we have children because P300 it is developing after certain age. Around the puberty. Meanwhile, the mismatch negativity can be used also in newborn, and this is comfortable because it doesn't require active attention. So the application of mismatch negativity, dyslexia, schizophrenia. I'm going a little bit fast here because I don't know how profound to go. Just I would like to mark some important things in order to develop your interest that you go and read in this direction. And I think that my job today is this, to give you one idea and to develop your desire to read in this topic. So then we can record evoked potential during Stroop test. You probably know what is this. It is when on the screen we have appearing letters and colors. They can be in one color, they can be synchronous. For example, yellow written with yellow or yellow written with green. And this is very heavy work for the cingulate cortex. So if we record evoked potential during Stroop test, this can be very useful when we study, for example, attention deficit disorder. Okay, I will skip this. Visual evoked potentials, usually the most used in the practice, I would say in the research practice. This is the recognition of the faces, and then it is studied usually N170. Again, this is useful for dyslexia, schizophrenia, for social cognition studies. So here I would like to underline, if we have just one parameter, we cannot make conclusions just because of one parameter. Okay, we have low alpha peak frequency, for example. You should never go to make fast conclusions. Use several parameters and see how this is making the puzzle. Otherwise, it is very dangerous to go in wrong interpretation. So always combination of different parameters, and if only they are going in one direction. For example, low alpha power plus low alpha peak frequency plus maximum alpha maximum, move it to the more frontal than usual, then we can think about Alzheimer and suspect, but not just one of these separately taken. Here, again, I would like to underline the QEEG. It is important where we have soft signs and where we have disease that are multifactorial and that can have different pathophysiological background. Then, in these cases, the QEEG is important to understand the pathophysiological mechanism and can be used for monitoring the therapeutic effect. So, there has been one big publication in regard to attention deficit disorder, and there has been identified just on the basis of QEEG 5 subtypes. I think that actually 5 subtypes, but only on the basis of the absolute power. So if we take under consideration different other parameters, the subtypes can go and to become much more. So, why this is important? First, because it can give idea for different mechanisms. Then this can give answer how we should approach the certain child, the certain subgroup of children. They will require different therapeutical approaches. We can use the QEEG when we already started with the medication in order to see if our medication is going in the right direction. Okay, here two examples. On the behavioral levels, the both patients have been diagnosed with attention deficit disorder. And what it appears, okay, you see that they are looking very differently on the EEG mapping. And it appeared that the first case, the problems, attention deficit hyperactivity problems, they are coming from food sensitivity. So when just the diet was adjusted after 3 months, the syndrome disappeared. And then the second case, it was question of cocaine dependence that appeared like clinically, okay, like, so it is difficult for the psychologist, for example, only to assess and to understand if the person has these problems, but when it is already on the EEG, certain parameters that are so-called, we can say, typical changes, then it is difficult to escape from the real diagnosis. I told you about application in autism, and here I will show you something very typical for all children with autism. This is disturbance in the connectivity between the somatosensorial area and other areas. Here a little bit difficult to see, but this is a child that has clinical improvement, and it is, okay, I will try. This is the connectivity before treatment, and this is connectivity after treatment. So there was clinical improvement that was parallel with the EEG changes. In dyslexia, it is also interesting. You are already hungry and your attention span is going down. I understand. Okay, just to mention, it is important also in dyslexia, which we have there at least 3 subtypes. Okay, this one just is showing. Okay, I'm going fast, just with most important things. This is showing the effect of transcranial direct current stimulation. So this is example how you can assess the effect of your intervention, non-medical, on the brain. And you can see that okay, this is the connectivity before the treatment, and this is connectivity after treatment. So the blue decreased significantly, what can be interpreted with improvement in the connectivity. And I thank you very much and for being patient and for your questions. It was a pleasure for me.
Thank you. Ok, preguntas, ¿tienen algunas preguntas? O si quieren, anotan las preguntas y hablamos en la tarde en el panel, como ustedes quieran, porque todos tenemos cara de hambre. Everybody are hungry. Ok, entonces nos vemos a las 2 de la tarde. Continuamos esta tarde con potenciales